Hey guys, welcome back. It's Tuesday morning, and today we are going to be talking about cardiac output. So let's get started. Now, when you think cardiac output, you're thinking, okay, hypoperfusion, perfusion. This is something that I absolutely need to know. Yes, it is. It is something you need to know. But, it's really one of those equations that we know, and then we kind of look for how we're going to alter it depending on our patient's symptoms. Because we're not sitting there going, oh, let me calculate their cardiac output. Because we as EMS providers cannot distinctly measure one of the functions of the formula. Okay? So now let's break down the actual formula for cardiac output. Cardiac output, okay, is what we want per 1 minute. Okay? So we're going to say per 1 minute. Okay? So cardiac output is equal to stroke volume, which is measured in milliliters per single beat, one beat. Milliliters per beat times multiplied by the heart rate, which we in turn measure as beats per minute. Okay? So when we're doing this equation, the stroke volume is really what we have to focus on because there's three distinct things that manipulate the stroke volume. Okay, and we're going to get into these in the next slide. But they're preload, afterload, okay, and don't worry, I will define these in the next slide, and contractility, okay, okay. Those three things are going to manipulate the stroke volume, which then in turn will make the heart rate go up or down depending on what these factors are doing to the stroke volume, and in turn we will get our cardiac output per 1 minute. Okay? Now let's break this all down and actually see what it's doing inside the heart. So now we're looking at the larger picture of the heart here. So we still have cardiac output is measured or equals to heart rate times the stroke volume. Okay? And we know the stroke volume is preload, afterload, and contractility. Okay? So what do I mean by these? The preload is how much the ventricles will fill with fluid, okay, blood, prior to beating, and the force that these ventricles must stretch to accommodate all of this fluid. Okay? Makes sense? I hope it does. So typically we are going to see about 70 milliliters of blood within each ventricle that's ready to get ejected from the heart. Okay, so this 70 milliliters of blood volume has pressure pushed against the sides of the ventricles. That is going to be your preload. Okay, now afterload is a little bit more in depth. It's the pressure that the ventricles must overcome to eject this blood through these two valves right here. You have the pulmonic valve and the aortic valve. Okay, so these valves are closed, and when you have a beat, the ventricles beat up, these flaps open and allow blood into either the pulmonary artery or the aorta, depending on what ventricle you're talking about. So when we're determining the afterload, this pressure that these ventricles must overcome to effectively open up these two valves, we're going to be talking about systolic vascular response if we're talking about the aorta, okay, or pulmonary vascular resistance. Systolic vascular resistance or pulmonary vascular resistance, depending on which one we are talking about. Things like a PE here, or pulmonary hypertension, okay? Things that are going to be causing the pressure to be closing this valve, okay? Putting more pressure on that door so it can't open, okay? Things in systemic vascular resistance like aortic stenosis, okay? Or hypertension. All right, these types of things are going to be pushing down on that aortic valve. So we again we have to create more pressure from the ventricles to even be able to open these up. Okay, that's the afterload. And contractility is just how ready and how strong are these ventricles at that point in time. Are they able to actually contract and squeeze blood out? So things, if you have weakened muscle here, okay, say you had an MI or you have heart failure, okay, these are things that are going to cause tissue death in terms of MI, right? Or heart failure, you're going to have a very flabby, non-strong ventricle that's not going to be able to pump that blood out of the ventricles, okay? Is there a fluid imbalance somewhere within the body, okay? So when we're talking, especially preload, we want to know about fluid, okay? Are they hypovolemic? Do they have a low fluid volume? Is there less fluid coming into the ventricles to be able to go out into the body, okay? If we have decreased fluid, we are going to decrease our preload, which is then going to decrease our stroke volume. If stroke volume decreases, heart rate must increase to still get the same amount of blood out to hold perfusion, okay? So when we are looking for certain things, we're looking for blood pressure changes and we're looking for heart rate changes. If we have a low blood pressure, we should see a tachycardic pulse. This is going to make sure that we have cardiac output that still is able to perfuse everything. Hopefully all this makes sense to you guys. I know this is an absolutely crazy formula, and like I said, we don't really utilize it except for, we utilize it but not in writing. We look at it and go, hey, they're tachycardic and they're they're hypotensive. They're probably fluid depleted. Why? Are they septic? Have they taken too much of their Lasix? Are they bleeding and they're bleeding out? Or have they been, non-hemorrhagic type shocks, vomiting and diarrhea where they're getting rid of all of this fluid, okay? Do they have heart failure where the fluid is packing somewhere else and it's not returning back to where it needs to go within the ventricles, okay? These are things that we have to look for and how we kind of use the cardiac output formula without actually writing out numbers, okay? So hopefully this makes sense, and I will see you guys next Tuesday.